Hi, dear students. So, this is Dr. Kunal Agrawal, and we are going to discuss the questions asked in NEET GT12 in this particular session. Right? So, without wasting time, let's start with the very first question. Which of the following functional components of stomatognathic system plays a most critical role in guiding the development of dental arches and occlusion during early childhood? So, that's asking which of the following functional components of the stomatognathic system. Stomatognathic system as a whole comprises of the masticator apparatus, which includes the maxilla, the mandible, the dentoalveolar component of maxilla and mandible, that is, the maxillary teeth, the mandibular teeth, the tongue, most importantly, then the floor of the mouth, the hyoid bone, and the temporomandibular joint complex. So the entire lower face, the middle and the lower face, is called the stomatognathic system, and all the associated soft tissues with it. First option, tongue function and posture, temporomandibular joint growth pattern, eruption sequence of primary teeth, and nasal respiration. So I think it's a very basic question. It's a question which can be answered just by common sense because quite many theories are based on this particular particular functional component. So the correct answer will be tongue function and the posture. The tongue plays a very critical role in the overall development of the face. Let's see how. You already know about the Buxton mechanism. We have talked about it multiple times earlier. So the balance between the facial musculature and the inner musculature, that is the tongue, the balance between them, that balance is a guiding force behind the proper and uneventful eruption of the teeth into the proper relationship. Okay, so tongue function and posture is one of the most important functional components of stomatognathal system, which plays a most important role in the overall development of the dental arches. Next question. Which of the following muscular dysfunctions is most commonly associated with development of anterior open bite malocclusion? I think again this is a simple question. Hyperactivity of the buccinator muscle, hypotonic orbicularis oris with tongue thrusting habit, overactivity of the masseter muscle, and weakness of the suprahyoid group of muscles. Now let's look at each option one by one. Hyperactivity of buccinator muscle, what do you think would be the sequel? Hyperactivity of buccinator muscle. If buccinator muscle is more active than the tongue, what can happen? We can observe constriction of the maxillary arch, either unilaterally or bilaterally. That's what we have seen in case of disturbance of the buccinator mechanism earlier. When the patient has open bite, when the patient has, you can say, the thumb sucking habit. In that case, the buccinator mechanism is disturbed, and we see constricted maxillary arch. Hypotonic orbicularis oris with tongue thrusting habit is the only reason, is the only causative factor behind anterior open bite malocclusion. Okay. Then overactivity of masseter muscle. What happens? We can have a skeletal deep bite in that case. The patient will have a horizontal growth pattern, a hypodivergent growth pattern, and in most common scenario, clinically, we are going to observe that the patient has skeletal deep bite and weakness of suprahyoid group of muscles. Suprahyoid, the digastric muscle, and other muscle which join the mandible to the hyoid bone. That comprises of suprahyoid group of muscles. So we can have other problem associated with that in case of its weakness, uh, like inability to swallow properly, inability to produce certain sounds of the speech, and so on. Okay, so option B will be the correct answer in this particular question. Third question. According to Enlow's counterpart principle, which of the following best explains the balanced growth of craniofacial complex? Now, Enlow had given two concepts, Enlow's V principle of growth and Enlow's counterpart principle. So, what does it say? Let's look at the options. Growth of the maxilla occurs independently of the mandible. Growth of one skeletal unit is compensated by growth or remodeling in another unit. Cranial base growth ceases before maxillary and mandibular growth begins. And growth of the mandible is determined solely by condylar cartilage proliferation. Now, counterpart principle, let's look at the principle behind it. What it says that if there is a growth associated in a regional region, Let's take an example of maxilla. For example, if the maxilla is growing properly, some other structure in the craniofacial complex is supposed to grow in that pace, in that direction, in order to maintain that equilibrium, right? So that corresponding structure, which has to grow, which has to keep pace with the growth of the maxilla, is called a counterpart, right? So whenever the regional part grows, the counterpart also has to follow suit in order to maintain a proper balanced growth of the stomatognathic system. That's the main principle behind Enlow's counterpart principle. Okay, so there are certain examples. So the part is anticranial fossa, which contains the forebrain, and counterpart will be the nasomaxillary complex. The middle cranial fossa, the counterpart will be the horizontal dimension of pharyngeal space. Middle cranial fossa, we have one more counterpart, that is the breadth of the ramus. Maxillary arch, the counterpart is mandibular arch, and bony maxilla, the counterpart is corpus or the body of the mandible. Right? You have to remember these examples. They can be asked to you in a number of ways, like a direct question, like a factual question, or like match the following. Right? In that case, you have to remember this particular box. Let's look at the options again. So balanced growth of the craniofacial complex is best described by option B. That is, growth of the skeletal unit is compensated by growth or remodeling in another unit. As I just explained, that is a whole mechanism, that is a whole principle behind Enlow's counterpart principle. Okay, next question. Which of the following wrought alloys is primarily used in orthodontics for its supra-elastic properties and shape memory effect, making it ideal for initial alignment and labeling phases? Again, a very easy question. Is it stainless steel, nickel titanium, beta titanium, or cobalt chromium nickel? What do you think should be the answer? We have discussed this again earlier many times. So there is always a sequence of arch wires which have to be used in orthodontics. First, we have to use flexible wires, thin flexible wires to provide lesser magnitude of forces, but for a longer range duration. That is the objective, right? So that property of superelasticity and shape memory is exhibited by none other than nickel titanium. Okay, so this is what the classification of orthodontic arch wires is. As I was saying, we have to go sequentially. We have to first start with round wire of a lesser diameter, then goes to rectangular wire, and then we have to finish in a higher with a higher dimension in the rectangular wire. Okay, so we have round wires in these many different diameters, rectangular wires in these many different diameters, square wires in 0.16 into 0.6 inches, and we can also use multi-stranded wires like coaxial wire, twisted wire, braided wire. But each and every wire has got its own different indications and contraindications. Okay, so I'm not going into much detail. The only thing what you can remember out of this particular table, the sequence what we use, we are going to increase that force levels constantly, appointment after appointment, appointment after appointment. So that process, as said by Burstone, is known as variable modulus orthodontics. Now, what's the meaning of modulus? Well, modulus here, it depends on the what do you say, that modulus of elasticity of the material. So nitrile has got the least stiffness and the least modulus of elasticity, and stainless steel has got the highest modulus of elasticity and highest strength. Okay, so we are increasing, we are going from the lesser wire to a higher wire. So that is why it is called variable modulus orthodontics by Charles Burstone. Okay, all right. Next question. Which of the following statements accurately describes the primary mechanism by which Invisalign clear aligners move teeth during orthodontic treatment? Again, quite a simple question. Invisalign aligners use high frequency vibrations to stimulate tooth movements. No, it doesn't happen that way. Invisalign aligners apply gentle, continuous pressure to specific teeth, gradually moving them into desired positions. Yes, we can consider this particular option. Invisalign aligners are designed to pull teeth outward using elastic bands. Again, not a feasible option. And Invisalign aligners utilize magnetic fields to reposition the teeth. No, it doesn't. So that is the main principle behind how Invisalign aligners actually work within the mouth. So these aligners apply gentle and continuous pressure to specific teeth, gradually moving them into desired position. And because the aligners are removable appliances, you already know the type of force generated by removable appliances falls under the category of intermittent forces. Please remember this. Aligners fall under the category of intermittent forces, not continuous, not interrupted. It's intermittent because it's a removable appliance. The patient can remove the aligners themselves and put them back themselves only. All right. So that's why these aligners are changed in 1 week or 10 days depending. Usually the time duration for changing of these aligners ranges from 7 to 10 days. It also varies from clinician to clinician, but on an average, every patient changes the aligners every 7th to 10th day. Right? During that time, the amount of tooth movement possible by each aligner falls approximately around 0.25 millimeter, 1/4 of a millimeter. Okay? So option B is the correct answer here. Next question. Which of the following properties best distinguishes wrought alloys used in orthodontics from their cast counterparts? So the difference between cast alloys and wrought alloys. Can anyone tell me what's the difference between them? Basically, the chemical composition is the same of both cast alloys and wrought alloys, but the physical properties are different. The wrought alloys are a little better in terms of physical properties as compared to cast alloys. And that is possible by, okay, let's look at the options. Higher modulus of elasticity due to grain boundary strengthening, increased strength from cold working and strain hardening, superior corrosion resistance because of elimination of casting porosity, and improved aesthetics due to reduced oxide layer formation. What do you think should be the answer? As I said, even though the chemical composition of cast alloys and wrought alloys is the same, still they are different. In what? In what? In what category? They differ from each other only in terms of physical properties. Wrought alloys are better in terms of physical properties because they are cold worked and strain hardened. So because of that, the strength is increased. Okay. So option B is the correct answer here. Next, this is an interesting question. I'll explain in detail. Which of the following mechanisms primarily explains the corrosion resistance of stainless steel orthodontic wires used in clinical practice? The question is asking about the mechanism of corrosion resistance of stainless steel. Why is it called stainless steel? Stainless steel. They say na, दाग अच्छे हैं, that aerial ad. Similarly, stainless steel, the steel which is devoid of any stains, is stainless steel. Formation of a passive chromium oxide layer on the surface, high nickel content providing improved electrochemical stability. Then we have cold working during wire drawing, eliminating surface defects, and addition of carbon which enhances hardness and prevents corrosion. What do you think should be the answer? Again, it's a very simple question. There's always a formation of passive chromium oxide layer on the surface which prevents the underlying molecules, underlying layers from oxidative stress, oxidation from the atmospheric oxygen. So that creates a layer of chromium oxide on the topmost surface of the substance, right? And it is protective in nature. That's some basic mechanism of corrosion resistance of stainless steel orthodontic wires. Now, that effect is known as passivation. This effect is known as passivation. Okay, what is passivation? Let's take a look. Resistance to tarnish and corrosion of stainless steel is because of passivating effect of the chromium. The chromium in the stainless steel forms a thin, adherent, transparent but tough and impervious oxide layer on the surface of alloy when it is subjected to an oxidizing atmosphere as mild as clean air. That oxygen within the air, within the atmospheric gases, that combines with chromium and forms chromium oxide. This protective layer prevents further tarnish and corrosion by blocking the diffusion of oxygen to the underlying bulk alloy, and this effect is known as passivating effect. Now, for this effect to take place, a minimum of 12% of chromium is required. If the oxide layer is ruptured by mechanical or chemical means, a loss of protection against corrosion results. Okay, so that is about passivation. Now, how does passivation occur chemically? What's the chemistry behind it? Let's take a look. We already know it's a process which prevents underlying tarnish and corrosion. Okay. Now, chromium is added to the steel. Why is it preferentially added? Because chromium plus oxygen forms chromium oxide passivating layer on the steel surface. That is what I was talking about. That layer is completely impervious to even more atmospheric oxygen, right? Now you have an MCQ here. I have seen many people doing a very silly mistake. A question is like, what is the maximum content? I mean, which element has got the maximum content in stainless steel? Options are chromium, nickel, iron, or let's say one more option, one more, chromium, nickel, iron, or carbon. That is the question. Which of the following elements is present in the highest quantity? I have seen many people marking chromium. It's absolutely false. It's a blunder if you do that. It's always 18:8 stainless steel, 18% chromium, and 8% nickel. But what about the rest? Okay, fine. Chromium is more than nickel. 18 plus 8, it's only 26% combined. Right, but what about 74%? What about 74%? 74% is made up of iron and just 0.1 to 0.2% of carbon. So you see, the bulk of stainless steel is made up of iron. It's not chromium. So please don't make the silly mistake in the exam. I have seen people doing that. That's why I'm stressing again, it's a blunder if you do that. So correct answer will be iron at any cost. Okay. Now what happens? If the chromium were not there, then we would have seen the formation of iron oxide. If chromium were not present within the stainless steel, now this iron oxide is nothing but rust. And rust is a product of tarnish and corrosion. Corrosion is an electrochemical process which degrades the particular metal from within. That is called corrosion, and rust is a form of corrosion. Okay, and the passivating effect is given by 12% chromium, right? Now there is one more process called sensitization. Now, okay, now we have added chromium to the steel. We want chromium to add to the steel in order to make it impervious to atmospheric oxygen, correct? But everything has its pros and cons. That is a pros. But what is the cons? Chromium, when added to steel, it reacts preferentially with the carbon to form chromium carbide along the grain boundaries. And that causes corrosion again. This is what is happening. So these are the grain boundaries. These lines, these black colored lines are called grain boundaries. Now what happens? chromium plus carbon forms chromium carbide that precipitates at the grain boundaries. This precipitation of chromium carbide at the grain boundary accelerates corrosion from within the substance of the metal. But we don't want that. Again, so there's a solution to it. What is the solution? Solution is stabilization. Stabilization means we are adding 6 parts of titanium as compared to chromium. We are adding 6 parts of titanium as compared to chromium because we want selective precipitation of titanium carbide instead of chromium carbide at the grain boundary. And the chemical property of this particular compound, titanium carbide, is that it stabilizes the grain structure and thereby prevents corrosion. We want the development of titanium carbide instead of chromium carbide. That's why we are adding 6 parts of titanium so that the carbon preferentially reacts to titanium instead of chromium to form a more stable structure, that is titanium carbide, which stabilizes the grain structure, which in turn prevents the further corrosion from happening. Right? So we want to increase the life of that particular metal. Okay? For that reason, we add 6 parts of titanium to 1 part of chromium. Okay? That is stabilization. Next question. Which of the following minor surgical procedures is most commonly indicated in orthodontics to facilitate eruption of an impacted canine? We have seen this again. We have seen this in the chapter on minor surgical procedures. Options are corticotomy, pericision, surgical exposure with or without attachment bonding, or alveoloplasty. What do you think should be the answer? Again, it's a very simple question, logical question. Option C will be the correct answer. That is surgical exposure with or without attachment bonding. Now, whenever you encounter an impacted canine in day-to-day clinical practice, we have got different treatment options. First is to leave it alone. That is, we cannot do anything about it. It's way too highly impacted. So no treatment. Second option is to extract the tooth, which happens very rarely. So in all probability, in an orthodontist and surgeon's capacity, we want to track that impacted canine and bring it into proper occlusion, right? Third is only surgical exposure in case of favorably and superficially positioned tooth. Now, once we do a CBCT scan, we have to localize the canine. We have to exactly localize whether it is deeply located within the bone or it is superficially located just beneath the soft tissues. If the latter is the case, if the tooth is just beneath the soft tissue, we can just only surgically expose the tissues in the area of the bulge and let the canine erupt on its own. We don't even have to bond an attachment. I've seen patients like that. I have done it myself. We can just expose the tooth by laser or by a scalpel blade and let the tooth erupt on its own. Whereas in the first case, if the tooth is way too high within the bone, in that case, we have to raise the flap, we have to gutter the bone, we have to do the bone guttering, and it is divided into 3 phases. Pre-surgical phase, surgical exposure, different types of flaps are there. Apically repositioned flap, closed flap eruption, open flap eruption, and tunnel technique. And finally, we have the post-surgical phase in which we orthodontically track the tooth into proper occlusion. Right? Now, what are the mechanical approaches to align the unerupted tooth? It consists of 2 stages, namely pre-surgical and post-surgical. Pre-surgical, it involves creation of space for the exposed tooth and stabilization of rest of the arch with a heavy arch wire. And post-surgical phase is when the actual orthodontic treatment begins. Nitinol wires to align the impacted tooth. We sometimes have to use auxiliary alignment springs to align the impacted tooth. Example, PG springs. Example, monkey hooks. monkey hook, or monkey chains. We can even bond peg bracket, right? There are many ways of bringing the tooth outside. We can use different kind of mechanics. These are few of them. Okay, so correct answer will be option C. Next, which of the following biological principles primarily underlies the effectiveness of corticotomy assisted orthodontics, that is Wilcodontics, in accelerating tooth movement? Now, Wilcodontics, we have again talked about it earlier. It's a process to accelerate the biological tooth movement. It was first described by Wilco and Wilco. Both were brothers. That's why, to honor them, a separate technique has been named after them. That is called Wilcodontics. It's also called periodontally accelerated osteogenic orthodontics, abbreviated as POW. Periodontally accelerated osteogenic orthodontics. Okay. First option, increased osteoclastic activity due to microtrauma initiating regional acceleratory phenomena. Decreased periodontal ligament vascularity and reducing resistance to tooth movement. Enhanced mineralization of alveolar bone, improving anchorage efficiency. And direct mechanical weakening of teeth due to corticotomy cuts. What is the answer? The biological principle behind accelerating any tooth movement is totally and entirely a phenomena called as regional acceleratory phenomena, RAP. That's called RAP. Now, what happens in this case? This is an example of corticotomy. What are we doing in corticotomy? We have a patient in the very first figure on the top left side, who he might be an adult patient, he or she, who is in need of accelerating the tooth movement. Right. So what do? We open the flap, we give a degloving incision, we open the flap, we expose the roots, right? We do that. Then using a piezotome, we create certain osteotomy cuts involving only the labial cortical plate. That's important. We have to involve only the labial cortical plate. Only the labial cortical plate has to be osteotomized. We are not supposed to touch the lingual cortical plate. Okay. After that, we insert certain graft material into it, and then we close the flap. Now, what happens? Graft material I was talking about, that is demineralized freeze-dried bone. Again, one more MCQ for you. What is the graft material used in corticotomy? So you have the answer right in front of you, that is demineralized freeze-dried bone. What happens then? A local response called regional acceleratory phenomena, where there is increased bone remodeling in response to local traumatic stimuli. This increased bone turnover peaks around the 3rd month following surgery and might continue for about the 4th month. Now, what is happening? You are intentionally creating certain micro trauma to the teeth. I just said now we do the corticotomy of the labial cortical plates. So we are intentionally inducing the trauma. We are inducing the trauma to the teeth. Now, because of the trauma, there is inflammation, and whenever there is inflammation, there is influx of inflammatory mediators, especially the cytokines, right? So those inflammatory mediators, that's also called cytokine storm. Cytokine storm. So the influx of these cytokine storms, that leads to bone remodeling, bone turnover at a very high rate, right? So whenever the bone is getting remodeled at very high rapid rate, so does the tooth movement. This phenomena is known as regional acceleratory phenomenon, RAP. Okay. In patients with complete unilateral cleft lip and palate, the primary orthodontic objective during mixed dentition stage is Orthopedic expansion of the maxilla to correct transverse deficiency. Alignment of teeth adjacent to the cleft using fixed appliances before alveolar bone grafting. Preservation of arch form and space until secondary alveolar bone grafting is performed. Or immediate closure of residual orodental fistula with orthodontic appliances. Now, any objective of primary orthodontic treatment during mixed dentition is alignment of teeth adjacent to the cleft using fixed appliances before alveolar bone grafting. You know, the secondary alveolar bone grafting, it has to take place between 9 to 12 years of age. That has to be concomitant with the timing of eruption of the maxillary canine. We have seen earlier, we have discussed about it earlier, that whenever the tooth has a solid bone foundation, it is easier for the tooth to erupt on its own rather than having to make the tooth erupted. That is a primary mechanism why alveolar bone grafting is important. We have to facilitate the eruption of the canine. For that, we need secondary alveolar bone graft by autogenous bone graft. We have to harvest that bone graft from the iliac crest, and that cancellous bone from the iliac crest has to be inserted into the cleft of the alveolus between the first premolar and the lateral incisor, if the cleft is in that area. Okay. Next question. Which of the following limitation of intraoral scanners is most clinically relevant when recording orthodontic patients with partially erupted molars and subgingival margins? Its difficulty in capturing accurate occlusal relationships, incomplete data capture in areas with excessive saliva and soft tissue interference, excessive radiation exposure during scanning. There is no radiation exposure in scanning. Inability to export STL files format for appliance fabrication. Also, this is not the scheme. So there could be difficulty in capturing accurate occlusal relationship, but option B is more relevant. It makes more sense clinically. That is incomplete data capture in areas with excessive saliva and soft tissue interference. Let me show you one of my own cases. I had a problem in one of my cases. I'm showing that to you. Now, this is a crown preparation I did in one of my own patients. I did a scan and sent the digital file to the lab for fabrication of the crown. All is well here. This is one more case of a first molar of the first quadrant. All is well here as well. And this is the occlusal view of the same tooth. All is well here also. You can see we have properly well-defined margins. Even though the margins are subgingival, the scanner was able to capture those margins in a very dignified manner. Now the problem arose in yet another patient of mine. I did a root canal treatment in 4/7 in this particular tooth. You can see, and I prepared the tooth for crown, for receiving a crown, and then I did the scanning. But because it was a second molar, it's far beyond in the depths of the mouth, where it is difficult to maintain isolation properly. So because of excessive saliva and sometimes bleeding also, as you can see in this particular case, this is the saliva droplet, this is the bleeding, which was not properly captured by my scanner. I used an iTero scanner. Okay, so this is what the problem was. I sent this particular STL file to the lab, and the lab person said, sir, you have to repeat the scan. You know, this part of the tooth was perfectly fine. 3/4 of the tooth was fine, but the mesial 1/4 of the tooth was not proper for 3D printing. So I had to call the patient again the next day. I had to repeat a scan. So the reason why I'm showing you this picture is that whenever there is inability to maintain proper isolation, and whenever there is saliva, whenever there is bleeding, you have to wait until the bleeding and saliva has stopped, and then you are supposed to take the scan for better accuracy. Okay. All right. Next question. If The outer bow of the face for cervical headgear is passing below the center of resistance of maxilla and above the center of resistance of the maxillary dentition, it will cause. Now it's a conceptual question. Let's look at both scenarios. Now this is the C rest of the maxilla, and we have the C rest of the maxillary dentition. Let me zoom in. Okay, this is the line of force of the outer bow. Now, when the line of force is passing below the C rest of the maxilla as well as the maxillary dentition, you observe a clockwise rotation of both the maxilla and the maxillary dentition whenever the line of force is passing below the C rest. In the second scenario, the line of force is passing below the C rest of the maxillary center of resistance, but it is passing above the C rest of the maxillary dentition. In that case, you observe clockwise rotation of the maxilla, but anti-clockwise rotation of the maxillary dentition. This is the biomechanical principle behind headgear. Right? Again, we see clockwise rotation here as well as here. Because the line of force is passing below the center of resistance of both. But in the second case, even though the line of force is passing above, so most probably this is a high pull headgear, and the previous one was a cervical pull headgear. Again, we'll observe clockwise rotation of the maxilla and anti-clockwise rotation of the maxillary dentition. Okay, now let's take a look at the options. Clockwise rotation of the maxilla and anti-clockwise rotation of the dentition. Clockwise rotation of dentition and anti-clockwise rotation of the maxilla. This is not the scenario. Both will rotate anti-clockwise. Again, this is not the scenario. Does not depend on the direction of outer bow. It does, of course, it does depend on the direction of the outer bow. So the correct answer will be option A, as I just explained in the biomechanical principles of headgear. Best material for alveolar bone grafting is, I just talked about alveolar bone grafting. So the best material is, it's an autogenous bone graft, which is harvested from iliac crest. What is iliac bone? It's one of the bones of the pelvic girdle, right? But the surgeon has to be very careful from where the graft has to be harvested from the iliac bone. You see, because iliac bone is a flat bone, there's an insertion of a muscle called psoas major. So the surgeon has to be very careful in assessing the area where the psoas major muscle is inserting. So that insertion point, that insertion area of the psoas major muscle doesn't have to be disturbed. So the surgeon has to make a drill within the bone such that the psoas major muscle is left uninjured. Okay, so that is what the major point here is. Next question. Mild decalcification of tooth enamel, that is clinical color change, white to white yellow, is seen during orthodontic treatment. This is the clinical presentation. Which of the following is the most effective approach to prevent this? By using fluoride toothpaste without rinsing with water, by using topical fluoride gel or rinse twice daily for 6 months. There is no need for any fluoride supplement. The decalcified enamel will remineralize on its own. Or option B, both A and B. What do you think should be the answer? We can use topical fluoride rinse or gel twice daily for 6 months. Also, there could not be any use of any fluoride supplement. There is a tendency for the decalcified enamel to remineralize on its own. So both options A and B are correct. But clinically, we should go with option B. That is always better to prescribe some fluoride topical gel or rinse to be used at least twice daily BD for 6 months. Pitch of the plan shown below is, what is the plan? It's a Hyrax screw. It's a Hyrax screw. Now you know what is a pitch? Pitch is the linear distance the screw travels upon 360-degree activation, 360-degree rotation. 360-degree rotation. That is what is called as pitch. So it's a factual question. The pitch of this screw is 0.8 millimeters. Upon a full activation of 360 degrees, the maxilla are going to separate, they are going to expand by 0.8 millimeter. Okay, but we do 90-degree activation at one time. So how much activation are we doing at single rotation? So 360 degrees divided by 4, that is 90 degrees. So 0.8 divided by 4, that is 0.2 millimeter per activation. This is the amount of activation what you are doing actually clinically upon rotating the screw by a quarter turn, by 90 degrees. All right. Next, identify the picture. Is it a continuous E-chain? Is it a short E-chain? Is it a long E-chain? Or is it an elastic thread? So without any doubt, you should be able to answer it's a long E-chain. Now, continuous E-chain is just like this. Okay, there is no intervening thread in between. Short E-chain, it's like this. Very, very small threads in between. Long E-chain is the one which is shown in the image. We have long interdental areas, and elastic thread is like this. It's just like it's a solid elastic thread. It doesn't have any lumen based modules. Okay, and it can be used for, since it is elastic in nature, it can be tied to the back bracket bonded to the impacted tooth, impacted canine, and that can be used to track the tooth downwards into the occlusal cavity in proper occlusion. Okay, that's all for now. This is the answer key for you guys. So NEET exam is just around the corner. You have to take care of yourself. You have to eat proper. You have to sleep properly. That's all I can say. I want all of you to succeed in for what you have been grinding so far since last almost 10 years. I want all of you to succeed in the NEET exam. Okay? May God be with you. All the very best. And if you have any doubts, you know where to find me. And whatever I can do to make you help cracking the exam, I'll do my best for you guys. All the very best.